I'm going to talk about the role of selective dorsal rhizotomy and peripheral neurectomy in refractory spasticity. Uh, uh, in my talk particularly, I've given more attention to selective dorsal rhizotomy because peripheral neurectomy has got very limited role in only focal spasticities and very straightforward procedure particularly. SDR is relatively more complex. There are multiple approaches, significant amount of intraoperative neuromonitoring lies behind the success of this procedure. So basically these are the two relatively common procedures apart from baclofen pump which are being done for refractory spasticity. So spasticity, as we all know, because spasticity basically can be categorized in two types. It is one spasticity which is helpful, another is one is harmful. So one has to consider that if whenever there is spasticity, it is present in a given patient, that doesn't mean that spasticity needs to be treated always. So we have to distinguish between whether the spasticity is harmful or it is helpful. Helpful spasticity per se means that the spasticity, wherever it is overlapping the weakness, in those patients, spasticity particularly helps in maintaining the posture. So it masks the underlying weakness. So that is what we call it as helpful spasticity. So this type of spasticity should not be targeted and should not be treated. So harmful spasticity, which means that whether it is either it is interfering with functional abilities or mobility per se, or it is refractory to medications, having significant amount of pain, and which is likely to be converted into permanent deformities. This is when that type of spasticity requires treatment. So what is the need? As I already mentioned, so spasticity is not the common singular problem. It is associated with many other problems. So spasticity is associated with significant amount of pain, abnormal postures, pressure points are there, orthopedic and spinal deformities which are associated with that. So all these things are the target of treatment whenever we are treating the spasticity directly. Apart from that, there are significant amount of nursing difficulties for caretakers as well as pressure point scare difficulty in bedridden patients. That is when that type of spasticity, when it is causing problems, it requires treatment. So spasticity is, as I have already mentioned, it is not a simple problem. It basically involves a vicious cycle which leads to hypertonia and further immobilization. That cycle goes on and ultimately it leads to irreversible deformities. So as I already mentioned, some amount of spasticity is helpful in many of the patients. So it is important that only the excess amount of spasticity has to be considered whenever we are treating the spasticity, so that patient has ease of mobilization and we can prevent further functional impairments or deformities. So when to treat? That is also an important question when we are talking about spasticity. In adults, if we talk about the spasticity treatment is quite straightforward. The treatment modalities are straightforward. The more complex scenario is in case of children particularly. So because if the surgery is done quite early in a given child, then it will be the potential for developmental neglect or developmental delay or developmental halt. And if it is done too late, then it would have already caused significant amount of deformities and permanent contractures. So in pediatric patients, it is very important to time, not particular time, but to do the surgery at correct time. So it is not only based on age itself. There are so many factors which have to be taken care when the decision is made. So considering the surgical options in case of treating spasticity, there are various neuromodulation techniques including intrathecal baclofen, lesioning procedures at various levels of reflex arc which involves the spasticity. It can be at the level of DRES in the form of dresotomy. at the level of dorsal root in the form of rhizotomy, and at peripheral lobe it can be in the form of selective neurotomy. And apart from that, as already mentioned, there are various deformities which are involved, spinal deformities, limb deformities. So various plastic surgical and orthopedic as well as spinal procedures are also required at times. So it is very important that particular procedure, if we are considering for a particular patient, it has to be individualized for each and every patient. It is not like that if we have hammer and every problem seems nail. So one problem, one solution cannot be applied to each and every individual. So each and every individual has to be considered separately, and particular decision making has to be done in a particular scenario. Broadly, if we speak, the spasticity treatment is basically dependent on whether it is focal or generalized, or whether the deformities or problems are that the primary underlying disease, if we talk about whether the disease is temporary or it is a permanent, or it is a progressive disease, or it is the disease is already limited. All those factors are taken into account when we are considering whether intrathecal baclofen, selective dorsal rhizotomy or rhizotomy, botox injections, or peripheral neurectomies. So it is a multidisciplinary team approach, very important in decision making and successful procedures, which involves neurosurgeons, neurophysicians, pediatricians, orthopedic surgeons, physiotherapists, and occupational therapists, and so more. I'll not go into the details of history of rhizotomy, but basically initial experiments of Sherrington in cats, decerebrate cats, from that it was evident that rhizotomy helps in reducing the spasticity. And later on, the gentleman who is shown in the picture, who was Forster, he was the one who operated first human with rhizotomy. So considering coming to the indications or criteria for patient selection in pediatric age group patients. So it is very important that because selective dorsal rhizotomy only caters spasticity, not the dystonia. So which is very commonly being found in pediatric age group patients, especially those who are having cerebral palsy. So it is very important when we are deciding for selective dorsal rhizotomy that there should be predominance of spasticity, not the dystonia. The general motor function scoring has to be the severe grade of severity should be higher, and there should be no progressive neurological underlying genetic condition. Apart from that, patients who have spastic diplegia, there should be enough amount of power and integrity of the hip joint and muscles should be there, so that the patient should be able to maintain upright posture, and with good hip and core strength. It is the must needed prerequisite before deciding for selective dorsal rhizotomy, because it is a irreversible procedure. It will cause muscle weakness, and if it is the hips are already weak, then the actual ambulation which was possible before surgery, it might be lost after surgery. And if these patients are not able to stand with weak hip joint musculature, then it is better to consider that patient for intrathecal baclofen. Pediatric patients who have quadriplegia or spastic quadriparesis, intrathecal baclofen would be a preferable choice over selective dorsal rhizotomy. Ideal age, as I already mentioned, it is not that only the age which matters, but if you consider age particularly, then the age age limit from 2 years to 6 years is considered to be the ideal age, because by the age of 7, the typical adult gait pattern develops in children. There should be no permanent contractures or permanent deformities while we are selecting the patient for surgery. And very important thing is that patient should have very good social as well as rehabilitation support, because that is equally important after surgery. So in adult patients, as I already mentioned, it's not that complicated, but any patient with spastic diplegia or quadriplegia of non-progressive etiology can be considered, particularly patients with diplegia. Although recently there have been reports in patients with motor neuron diseases and other progressive disorders where patient is already significantly disabled, those patients get benefited by these procedures. Independent walking before doing the procedure, it is very important that patient should be independent, even though the patient should not be bed bound, and he should be able to walk at least with minimal support. In contraindications, relative contraindications or unsuitability for candidacy for selective dorsal rhizotomy are underlying severe traumatic brain injury, predominant dystonia, non-ambulatory quadriplegics, permanent severe spine and peripheral deformities, already over-lengthened Achilles tendon with equinus deformity, and even after doing the surgery, if we are not expecting any additional functional gain, then surgery should not be done. There are significant issues related to selective dorsal rhizotomy as compared to other neuromodulation procedures because it is a irreversible procedure. There is no effect on dystonia. It is not recommended to do selective dorsal rhizotomy in upper limbs, and there is many a times initial decline of function, but over the period of time there might be some gain in spasticity after surgery, and that cannot be modulated. And there are inherent surgical risks which are associated with selective dorsal rhizotomy. Pre-operative evaluation, routine evaluation is required, like MRI, whole spine. Apart from that, hip and lumbar spine X-ray is very important to note the integrity of the hip joint particularly. So coming to the selective dorsal rhizotomy, there are various approaches. Extended laminotomy approach from L1 to S1, limited laminotomy approach from T11 to L1 laminotomy, keyhole intralaminar dorsal rhizotomy at multiple levels, keyhole procedure which is being done, and minimally invasive single level, and at the level of L1 laminectomy is done to expose the conus, and the procedure is done. So the basic concept remains the same irrespective of the approach being used. The more important is the intraoperative neuromonitoring which is done in all the patients. So I'll not go into the details, but basically extended laminotomy is from L1 to S1. It is quite morbid. Prolonged hospital stays are required because it is an extensive procedure, and in most of the patients, irrespective of the approach used, L4 and S2, these are the two levels where caution has to be taken, and the section of those radicals, those nerve roots should not be done more than 50% because they are very important. L4 is important for knee stability, and S2 for hip stability as well as urinary continence. Limited laminotomy from T11 to T11 is the similar approach, and at the level of conus cauda, root identification and resection is done. Similarly, keyhole intranulnar multi-story approach, midline single incision is made, but rather than doing extended laminectomies or laminotomies, only L1 between L1 and L2, it is just like opening the window between the two lamina, and at the level of L1, L2, L3, L4 and L4, L5, laminotomies are done, and two roots at each level are addressed. Single level approach at only L1 laminectomy, and there the identification is done by EMG. I will come to it later about intraoperative neuromonitoring. So as I already mentioned, intraoperative neuromonitoring is very important and paramount importance for successful treatment of spasticity by SDR. So preoperative charting is very important to know about the target muscle groups which are involved significantly by spasticity and which are to be targeted during surgery. And there are basically anatomical and physiological mapping which is done. Anatomical mapping is done by stimulating the ventral roots, and physiological mapping is done by dorsal root stimulation. Various parameters are there of stimulation. So basically, based on ventral root stimulation, we know the level, we confirm the anatomical segmental level, and by physiological mapping, we determine the rootlets by which are contributing significantly to the development of spasticity in that given particular muscle groups. So the ideal technique is to combine both the things, anatomical and physiological techniques. So physiological mapping, whichever rootlets which are contributing significantly with grade 3 and 4, which means whenever we are stimulating the dorsal roots, there is spread and there is contraction response is found beyond that segment or even on opposite side, which is grade 3 and grade 4. These are the rootlets which need to be targeted and which need to be resected or divided after monitoring. So this is what I already mentioned. Combined anatomical and physiological mapping is the preferred technique which is being used. In anatomical mapping, ventral roots are stimulated at 2 hertz and 200 microamperes from the 200 microseconds from the range of 0.1 to 1 milliampere milliampere current, and those which are associated with a group of muscles which are associated with significantly high spasticity, those levels are targeted for dorsal root stimulation. And dorsal root stimulation is done by train of stimulus using 1 second duration 50 hertz train at 1 milliamperes. And wherever we find in whichever rootlets we find exaggerated response by grade 3 and 4, those are divided. So there is quite a lot of controversy. There is no consensus about rootlets, the portion of rootlets which have to be divided. There is a range of division which is being practiced from 1/3 to 4/5. On an average, around 2/3, around 66% of the rootlets are usually divided world over. But there have been individual practice differences which is there. And I already mentioned earlier, L4 and S2 are important roots, and as far as possible, not more than 1/2 of the rootlets of L4 and S2 should be divided. And coming to the complications of SDR, there are various complications which are associated with that because it is an irreversible procedure. Urinary disturbances, especially if S2 is cut by more than 2/3, dysesthesia, paresthesia, hypoesthesia, and hip subluxation and spine problems. These are all the possible complications associated with that. So to conclude, each and every patient has to be considered individually. It is a holistic approach of all the treatment modality should be considered for that given patient, and whichever treatment modality is best for that patient should be considered for final treatment management protocol has to be considered according to that. And goal is to have the functional gain, rehabilitation, nursing care, and prevention of deformities. And teamwork is very important, as I already mentioned. Thank you.